Hi, this is Nurse Inga, and you're watching Schizophrenia Spectrum and Other Psychotic Disorders. Two core concepts. 1. Psychosis. Psychosis is when you experience disorganization of personality, deterioration in social function, and loss of contact with reality. The patient who is psychotic is also often experiencing hallucinations and delusional thinking. The patient with schizophrenia may be experiencing an entire spectrum of disorders that display psychotic behaviors. From least to most severe, these include schizotypal personality disorder, delusional disorder, brief psychotic disorder, substance-induced psychotic disorder, psychotic disorder associated with another medical condition, or catatonic disorder associated with another medical condition, schizophreniform disorder, schizoaffective disorder, and schizophrenia. To focus a little more closely on some of these psychotic disorders, delusional disorder is when someone has a prominent, non-bizarre delusion. And these include erotic delusions, where the person believes that someone, usually famous or higher status, is in love with them. Grandiose delusions, where they have an irrational idea regarding their own worth, talent, knowledge, or power, and they may believe that they have a special relationship with a famous person, or even believe that they are that famous person. The jealous type occurs when they focus on an idea that their sexual partner is unfaithful, and it's usually irrational and without cause. They will search for evidence to justify this belief and oftentimes will attack the person that they believe is the lover. Persecutory delusions include the person being treated in some poor or malevolent way. They think that they're being plotted against, cheated, defrauded, followed, spied on, poisoned, or drugged. They obsess or exaggerate even the most slightest rebuff, and they may repeatedly call legal authorities to complain or report these beliefs. With somatic delusions, they believe that they have some type of a medical condition, and with a mixed type delusional disorder, they have a combination with no one prominent delusion. A brief psychotic disorder is where the person experiences sudden onset of symptoms that may or may not be preceded by a severe psychosocial stressor. They last less than 1 month and they return to their full premorbid level of functioning. Schizophreniform has the same symptoms as schizophrenia, except that the duration is less than 6 months, but at least 1 month. And schizoaffective disorder are schizophrenic symptoms with a strong element of symptomology associated with the mood disorders, either mania or depression, which usually do not exist with schizophrenia. Let's talk about the etiology of schizophrenia for a moment. With schizophrenia, we believe that there's a combination of genetic, physiologic, and environmental influences that have led to an imbalance in the monoamines that impair the thoughts of the person. A growing body of knowledge indicates that genetics plays an important role in the development of schizophrenia. Physiologically, we have evidence to suggest that viral infections, anatomical changes, and histological changes in the brain also can impact the development of schizophrenia. And then environmental stressors can exacerbate schizophrenia as well as increase the rate of relapse. Twin studies are pretty interesting because even identical twins, oftentimes only one will develop schizophrenia. But there is a genetic vulnerability that has shown that psychosis is genetically linked, especially for adolescents who use cannabinoids. So how is schizophrenia diagnosed? The patient must meet the following criteria for a full diagnosis of schizophrenia. They must have 2 or more of the following that occur a significant portion of a full 1-month period. Delusions and hallucinations are kind of darker font there because those must be present. And then so one of those must be present. And then at least one of these others, disorganized speech, grossly disorganized or catatonic behavior, and the displaying of negative symptoms. So delusions and hallucinations are considered positive symptoms, and then they must also have some negative symptoms. Typically, patients have significant social, work, and self-care impairment, continuous signs of the disturbance for at least 6 months, that may have remissions and exacerbations and may be successful with the treatment plan. They've ruled out schizoaffective disorder, major depressive disorder, and bipolar disorder 1, and there's no major depressive or manic episodes during the active phase of the disease. There's no evidence of substance abuse or medical conditions that cause these symptoms, and if the patient is rated to be on the autism spectrum, then they have prominent delusions and hallucinations in order to meet the criteria for schizophrenia. Positive symptoms of schizophrenia are when the person has extra content of thought, extra form or changes in form of thought, extra perceptions of the world around them, or an alteration in sense of self. Content of thought includes things like delusions, which are false personal beliefs that are inconsistent with the person's intelligent or cultural background. And they believe these things in spite of obvious proof that it's false or irrational. These include things like delusions of persecution, delusions of grandeur, delusions of reference, delusions of control or influence, somatic delusions, and nihilistic delusions. The patient may also present with paranoia, magical thinking, where they think that, if it snowed last night because I wished that it would, or something like that. With form of thought, they have looseness of association, where they have a hard time staying on topic. They shift from one thing to another even within a sentence. Neologisms, which they invent new words. Concrete thinking, where they have a hard time understanding or interpreting sentences. They have a very literal interpretation of everything. If you say, like, I'm so bored, I'm climbing the walls, they would think that you're actually climbing walls. Clang associations is where they love to rhyme things. So, it's very cold. I am cold and bold. The gold has been sold. Lots of words that rhyme. Word salad is just words that are put together randomly that don't actually form a sentence. It doesn't make sense. Circumstantiality is where they talk unnecessarily. There's like tons and tons of details. It's impossible to get to the point. You're trying to elicit information about something and you're getting this 2-hour long story where they keep adding in more details and more history that don't make sense. Tangentiality is where they can, again, never get to the point, but they just keep jumping from one topic to the next and going off on a tangent. Mutism is where they are unable or refuse to speak, and perseveration is where they repeat the same word or idea over and over again. Hallucinations are a problem with perception, and this is a false sensory perception that's not associated with real external stimuli. It can involve any of the 5 senses. It could be auditory, visual, tactile, gustatory, or olfactory. Illusions are misperceptions or misinterpretations of real external stimuli. A patient who has an altered sense of self describes themselves or identifies themselves their experiences in a very confused or kind of altered manner. So with echolalia, they just echo what they hear. They can't form a sentence, or they can't think independently or whatever for themselves. Echopraxia, they imitate movements made by others. So they're not moving independently or thinking about what it is that they need to do. They're just mimicking the people that they're seeing. Identification and imitation usually occurs on an unconscious level, where the person is trying to kind of mimic the behavior of the person that they see around them. And depersonalization is when the person feels like their extremities or body parts have changed in size, or that they're seeing themselves from a distance, so they no longer feel like they're connected to themselves or their body. So they kind of lose that sense of self or self-control. So these are all kind of in addition to baseline or added to baseline. Negative symptoms, think about almost like a withdrawal from baseline or withdrawal into yourself. Affect becomes inappropriate, bland, or flat, and the person experiences apathy. Volition is the ability to initiate goal-directed activity. So there's a loss of volition. They're no longer able to initiate that goal-directed activity. Like, they can't get themselves dressed or brush their teeth or fed. They become emotionally ambivalent to anything. If you ask them if they want to eat or whatever, they can't even decide whether or not they want to, and their appearance begins to deteriorate because they aren't taking care of themselves, because they have no ambition to do so. Interpersonal functioning and relationships with the external world become impaired. They withdraw into themselves. There's no or little social interaction. They become socially isolated, and they start to experience a lack of just socialization. Psychomotor behavior, they have a decrease in energy. Waxy flexibility, where you can actually just be able to like pose them however you want them. So they allow their body parts to be placed in bizarre, uncomfortable positions, and they'll just stay in that position for long periods of time, regardless of how uncomfortable it is. So if you like raise their arm for blood pressure measurement, when you take it off, they will just leave their arm like that until you put it down. Posturing is when the person assumes inappropriate or bizarre postures. It's different than, it's not decorticate or decerebrate posturing. This is just like they put themselves in these really weird postures. And then pacing and rocking is just usually slow, rhythmic, back and forth swaying. Associated features that you also might see with negative symptoms would be anhedonia, which is the inability to experience pleasure, and regression, which is a retreat to an earlier stage of development. The pattern of development of schizophrenia has 4 distinct phases. The first one is the premorbid phase, which is prior to the disease. During this time, the person would be described as having poor social skills. They're maladjusted, they're withdrawn, irritable, inexperienced, antagonistic thoughts and behaviors. Their peers would explain them as being shy, withdrawn, having poor peer relations, doing poorly in school, and demonstrating antisocial behavior. Phase 2 is the prodromal phase, and this is where they transition from premorbid to morbid. So the disease begins, and this can be brief, which is weeks to months, but on average lasts 2 to 5 years. Functional impairment develops and increases, and we see sleep disturbances, anxiety, irritability, depressed mood, poor concentration, fatigue, and behavioral deficits. Positive symptoms such as perceptual abnormalities, ideas of reference, and suspiciousness develop late and signal the onset of psychosis. A severe mental condition with disorganized personality and thought. With psychosis, remember they have a deterioration in social functioning, loss of contact with reality, oftentimes hallucinations, and delusional thinking. In phase 3, we see the active disease or schizophrenia. During this time, psychotic symptoms are prominent. They have, again, the delusions, the hallucinations, disorganized speech, disorganized or catatonic behavior, and the negative symptoms such as decreased emotional expression. This lasts greater than 1 month and up to 6 months at least in order to be classified as schizophrenia, but again can be treated effectively and can come and go. In phase 4, we see residual phase where the active symptoms subside and they're considered in remission. The negative symptoms often remain and the person often is not normal. The prognosis for the patient with schizophrenia is poor. A return to full premorbid functioning is not common. Factors associated with a positive prognosis include good premorbid functioning, later age at onset, female gender, abrupt onset precipitated by a stressful event, brief duration of active phase symptoms, and no family history of schizophrenia. Treatment for schizophrenia includes therapy, medications, and sometimes ECT. Individual psychotherapy can be a long-term therapeutic approach, but sometimes is difficult because of the client's impairment in interpersonal functioning. Group therapy has demonstrated some success over a long-term course of the illness. It's less successful in acute short-term treatment. Behavior therapy is used to help the person modify their behaviors, but it's usually unable to generalize to the community setting after they've been discharged. So this is usually used for inpatients only. And then social skills training, we use role play to teach the client appropriate eye contact, interpersonal skills, voice intonation, posture, and so on for communication to improve their relationship development. Family therapy is critical because it provides families with the education and coping mechanisms, but it really enhances the chances of successful discharge and transition to outpatient life. The family needs to know what to do to support the patient with schizophrenia. PACT, or the Program of Assertive Community Treatment, is case management that takes a team approach to provide community-based psychiatric treatment. NAMI is the National Alliance on Mental Illness and provides a great deal of resources if you look at their website on kind of community-based care for the mental health. And then the recovery model. And this is engagement and empowerment of the client that's aimed at living a meaningful life. Recovery after an initial schizophrenic episode or RAISE is another program, and really the entire goal of this is to elevate the person back to their close as possible to their baseline functioning so that they can get back into the community and feel good about themselves. Medications that are used for the schizophrenia spectrum include antipsychotics, and these decrease agitation and psychotic symptoms. They work well on the positive symptoms such as the delusions and the hallucinations, but they don't do anything for cognitive problems and they don't really do anything for the negative symptoms. They're used for maintenance. Compliance is an issue due to the multiple side effects, and oftentimes when patients start feeling better, they don't want to take their meds anymore. It's important to encourage self-reliance and teach the patient about their meds and the schedule. Our goal really is that the patient can ask for the correct meds at the scheduled times in order to demonstrate that they're ready to move back into a community setting. Antipsychotics do have a black box warning for the elderly, and there is a debate about how early to start these medications versus therapy. Typical antipsychotics are strong dopamine receptor antagonists. and they have a various affinity for cholinergic, alpha-adrenergic, and histamine receptors. Atypical antipsychotics are weaker dopamine receptor antagonists, and they have strong serotonin receptor antagonists. These exhibit antagonism for cholinergic, histamine, and adrenaline receptors. Clozapine or clozaril can cause a granulocytosis. If the patient is taking that medication, they need to be reliable enough to have regular blood work because they can develop neutropenia and significant life-threatening infection. Signs and symptoms would be fever, malaise, sore throat, and they would need to be checked immediately. Other important side effects of medications include metabolic syndrome, photosensitivity, QT prolongation, a reduction in the seizure threshold, and EPS or neuroleptic malignant syndrome. When you're helping patients develop kind of a desire to be compliant with their medication, the things that you can do are to provide education. So talk to them about weight gain and good glycemic control. Talk to them about the maintenance of dry mouth and salivary problems, using lozenges, taking sips of water, things like that. Talk to them about the dangers of stopping their medication suddenly, and encourage the client to be involved in their own care and decision making. For clients that wish to take their meds and cannot remember, or for clients who don't wish to take their meds and are court ordered, patients who can't swallow pills, there are alternate routes of administration such as injection. Monitor carefully for side effects and give patients both verbal and written instructions to have at home that discuss the side effects that they should watch for and the side effects that they should report. There's an Ames scale for EPS. The treatment is cogentin. Orthostatic hypotension is more likely to occur with patients who are taking antipsychotics if they're combined with blood pressure medications. If the patient develops tardive dyskinesia, they should stop their medications, obviously under the guidance of a physician, tapering off and switching to something else. But tardive dyskinesia, may continue even after you stop the meds. And then neuroleptic malignant syndrome is life-threatening hyperthermia, muscle rigidity, and tachycardia. Thorazine, when used in long-term care, oftentimes those patients will appear septic. It's important, regardless of the cause, that they get sent to the ED. But if you have a patient on Thorazine who presents with an elevation in temperature, do not administer the next dose of Thorazine because that could be life-threatening. Instead, send them to the ER for evaluation, especially if you notice muscle rigidity. That is information about schizophrenia and the treatment. Thank you for watching.